Doctor, we are live, ma'am. Please start.
Let's start.
Yes, doctor, please.
Good evening, everyone. I am Dr. Akhileshwar Singh, an infertility consultant, endoscopic surgeon at Embryonic Fertility and IVF Center, Pune. Very good evening and warm welcome and happy Janmashtami to all of you, to all my viewers. I thank WebMD for inviting me to speak on a very relevant topic today, which I will be speaking on, which is when do we refer these infertility patients whom we are working on to an higher echelon, to an IVF or assisted reproductive technique clinic, where the higher treatment can be done. So I'll be covering the topic under following heads: the roadblocks where we falter, what is my primary goal, and the main reasons why we should refer these patients to IVF or ART centers. What are the methods and tools available with us in periphery or in hospitals where we can diagnose these patients and evaluate them early and send them to an IVF or ART clinic. Then some take-home messages. So what are the roadblocks? As a postgraduate student or a fresh pass out, I also used to feel that in vitro fertilization is the last resort treatment for any infertility couple, but it's not so. In some conditions, it is the first treatment. So we should remove this myth from our mind that IVF or reproductive medicine is a super specialty within the branch of obstetrics and gynecology. IVF can be an initial treatment for some of the problems a couple has, or they are diagnosed with some problems. So IVF can be the starting treatment in those patients. So in those diagnoses and those conditions, those patients should be referred to an IVF clinic urgently or at the earliest. Apprehension about the procedure. So the patient and even the doctors, the young ones, the young gynecologists are very apprehensive about the procedure, the whole procedure, the IVF. They're scared about the procedure, even the patients. So if we are not scared, then only we'll be able to counsel our patients and tell them where to go and how and why to go to IVF clinic and get the consultation there. Cost factor is a very important factor. So we should all discuss with patients why the IVF treatment is so expensive, and going to IVF center is not amounting to starting an IVF treatment. It amounts to evaluation, diagnosis, and correct management afterwards. Awareness. Awareness is very important amongst ourselves, the gynecologists, the young specialists, and IVF consultants, and the patients itself. So we have a lot of complication of IVF. There are myths that IVF is related to a lot of complications. So, and the last but not least, I have written in italics and a very small font, fear of losing patient. So even if the patient needs IVF treatment, we all, maybe some of us are fearing losing patients. But at the end of the day, we should all think about the patient's problems. And if they need to go to an IVF clinic, so they need to be referred early and at the earliest. So Richard Branson said, business opportunities are like buses. There are always another one coming. So there's no one losing anyone. So we should all think about the patient, their betterment, and send them to IVF clinic if they need it. So my primary goal is to sensitize the young gynecologists at periphery, in hospitals, not sitting in IVF clinics, and the patients to know the importance of early referral and to an IVF clinic for evaluation, at least to be seen by an IVF consultant and ART specialist. So as we say since a very long time, so do no harm. So refer early these patients. So right patients, if it goes to the right place at the right time, they can conceive early with no complications. So I'll not go into the details of theory of this topic, when to refer and what are the causes of referral to the IVF clinics. I'll just straight away go to some practical points. So what are the practical points? What are the upfront reasons for referral in a female partner? So upfront reasons means we diagnose these patients as one of these diseases or conditions, then these patients should be directly referred to IVF clinics, like tubal diseases. Tubal diseases including bilateral hydrosalpinx, bilateral blockages, history of tubal surgeries in past, any tuboplasty is done, tubal recanalization done, history of ectopic surgeries, any history of genital TB since childhood till date. These patients should be upfront referred to an IVF clinic for at least for evaluation, for any corrective surgeries, or any further management, they should be sent to an IVF clinic. Peritoneal adhesions because of many reasons, previous surgeries, any severe endometriosis. So these patients also should be diagnosed. And if they have poor ovarian reserve, they also should be visiting a nearest IVF clinic. Any Mullerian abnormalities, abnormal uterus in the form of abnormal myometrium, in the form of fibroids or any polyps, bigger polyps, or in the form of poor lining, poor endometrial lining. These patients also should visit an IVF clinic. Then diagnose pelvic tumor. In the case of female or a male, when they are diagnosed with pelvic tumor, married or unmarried, they also should be visiting an IVF clinic, because we have plenty of options available. Even if they have to undergo a chemotherapy or a radiotherapy for their tumor to remove the tumor, or for a medical management like chemotherapy or radiotherapy, they should be undergoing an IVF cycle just to retrieve the eggs if they are not married, or embryo freezing in case of they are married. So they can be referred to an IVF clinic early. Then the last but not the least, the poor ovarian reserve patients. The focus of this talk will be more on the poor ovarian reserve patients, because even if the young patients nowadays are coming with poor ovarian reserve. Earlier we have read as a postgraduate also in our study days, like after 35 years of age, the ovarian reserve starts decreasing. After 40, it becomes very less, and after 45, hardly any oocytes are left. But nowadays we are seeing the trend. Even 30 years old lady and 32 years old lady, they are coming with the poor ovarian reserve. So these patients also should be evaluated at least. There should be some tests should be done to diagnose poor ovarian reserve, and these patients should be sent to IVF clinic or ART clinic at the earliest. Upfront reasons for referral in a male partner, like azoospermia, severe oligoasthenoteratozoospermia, erectile dysfunction, undescended testis, varicocele, or other conditions which cannot be treated at a local level. They should be evaluated at least at an IVF clinic. They should be evaluated, and the management plan has to be told to them, counseled, and then to be seen by an IVF consultant. As a gynecologist, some conditions are there which we can manage at periphery or at hospitals, where we can manage these patients even before starting IVF or IUI cycles. Those conditions are just like PCOS, polycystic ovarian syndrome, patients suffering with oligo or anovulation, abnormal uterine bleeding, where we can manage these patients, evaluate these patients, even start some treatment for infertility, get some hormonal tests done. Unexplained infertility patients also, we can evaluate them, treat them at our center, failed IUI cycles, then we can further go ahead with further IUI cycles or diagnostics through laparoscopy. Then these patients can be referred to an IVF clinic at a later date when they need the treatment of a higher treatment. Age of the couple, as we all know, below 35 years, if they have been trying for 1 year and not able to conceive, they also should be referred to IVF clinic. And a patient of more than 35 years, if they have not been able to conceive for more than 6 months, then also they should visit an IVF clinic, and proper evaluation should also be done. Type of job, there comes the importance of history and clinical examination. We have been telling them that patient has been married, the couple has been married for 15 years, but when we ask the type of the job, then we know that they have been hardly staying together. Like if the husband is in armed forces, then also these patients should be evaluated at an early date. Then also they should be visiting an IVF clinic after proper evaluation, and they also should be sent to IVF clinic. Mild sperm abnormalities, like mild oligoasthenozoospermia, they also can be managed with medicines. Their sperm count can be upgraded or can be treated. Then also they can be treated at a peripheral center, and they can be sent to an IVF or ART clinic at a later date after evaluation. So I have written these methods used in our ART and IVF armamentarium, like in intrauterine insemination, IVF EP, ICSI, FEP, GIFT, ZIFT, pre-implantation genetic diagnosis, oocyte embryo donation, assisted hatching, TESA, and TESI. These are all methods used where when the patients come to us, so we can all use these methods to giving them pregnancy. So just for an example, we will not go into detail of all these procedures. Just for an example, a poor anatomical problem in the sperms can be treated with ICSI, or poor motility problems in sperms can also be treated with ICSI. So if the patient comes to us with a referral and we do ICSI, so the success rate in those patients also will be very high in those patients. So tools of assessment. What are the tools available with us? So we should all be doing all the hormonal tests for both the male and female partner. Tubal patency is very important. Basic pelvic sonography to look for ovarian reserve and enteral follicular count. Semen analysis, the basic test to be done in the husband or the partner. Detailed history and clinical examination, as I already told you, for evaluation and for better management at the periphery, and to do all the tests and to refer them in time to a higher echelon. So we are always confused to get all the tests done and then when to send these patients. So tools of assessment, if you zero down to hormones and tubes, then out of hormones, AMH, the anti-mullerian hormone, is the very important and one of the most important hormones in the assessment of infertility and enteral follicle count. These are all the tests of ovarian reserve. Then semen analysis. And I would like to focus on the Poseidon criteria also. As a postgraduate also, we have just read. We have not utilized this criteria to be incorporated in the assessment or evaluation of infertility patients. So this also should be done. My aim is to make this Poseidon criteria to be available with all the gynecologists at periphery or before referring them to an higher echelon to the IVF clinics. So what is the Poseidon criteria? When we diagnose these patients with low ovarian reserve or with AMH or low AMH or low enteral follicle count, so these patients are classified into 4 groups, are divided into 4 groups. So even if you can see like group 1 and group 3, they are younger patients, but younger patients with AMH of AFC of more than 5 or AFC of less than 5, AMH of more than 1.2 or less than 1.2. So these patients, if they are properly counseled, they should also be referred to an IVF clinic in time so that the treatment can start and they can get better treatment, better results. And these Poseidon criteria should be applied at a peripheral level because the application of this Poseidon criteria is very, very much like it's an objective method to assess prognosis. So where we can, it's very easy to counsel the patient at our level. Why we are referring these patients to the IVF clinic? What is the urgency? If the AMH is very low and age is just 26 or 24, these patients need to go to an IVF clinic, and with availability of this Poseidon criteria and other methods also, AMH and AFC, it's very easy to convince those patients. And we can always counsel them about the expected number of embryos based on this criteria. And role of PGD, if the patient is of the age of patient is more than 35, then always we can explain the role of pre-implantation genetic diagnosis. Then protocol of IVF treatment also we can decide based on these criteria, AMH, AFC, and the response to any previous ovarian stimulation. So Audrey Hepburn has said that nothing is impossible. As you know, the word itself says I am possible. So if we send these patients to IVF clinic and properly analyze them and evaluate them and do the management, so pregnancy is always possible, but the proper counseling and proper evaluation is always needed, and better communication with IVF clinic consultants. So there are some guidelines available from UK where they say that risk and benefits are to be discussed with the patients. And they say that 2 years of unprotected intercourse along with 6 or more IVF cycles, then these patients are there. Less than 40 years, these patients should be referred to IVF clinic. And if the patient is more than 40 years, this doesn't fit in our country. So if they are more than 40 years, then also they should be sent to IVF clinic directly. But in our country, the AMH falls very rapidly after 32, 34, definitely after 35. So these criteria don't fit in for our country in India. So we follow as we already discussed. I already discussed with you. So what are the take-home messages? Like IVF, not exactly an advanced treatment. It is an advanced treatment for an unexplained infertility where we have tried everything. We have done the surgery. We have diagnosed with something. We have done IVF for that patient. Still, she has not conceived a young patient with good AMH. Then we should go for an higher treatment in the form of IVF. But like in the case of ovarian tumor, where the patient is going to be treated with chemotherapy or radiotherapy, then we can do egg freezing, embryo freezing, and ovarian transposition surgeries. So if they are referred in time, so timely referral is very, very important, and application of Poseidon criteria at a periphery or non-IVF clinics is very important to convince patients, to counsel patients, and send them to a higher echelon. Visit IVF, and for a peripheral gynecologist, it's always very good to follow up your patient in the IVF clinic, what's going on there, and visit the IVF center yourself, so that you can know what are the other things, what are the other advances, and how the patients are counseled there. So I think I've explained in the form of a practical knowledge which should be useful to all the gynecologists at periphery. Why the patient should be referred to an IVF clinic in time and when they need it, so that pregnancy can be achieved at an early stage and at an early date. Thank you from my side. Any questions? Any, I can address them.